Good evening, everyone. I welcome you all to the sixth session of KSOS PT Classroom. Last week, we had a case-based discussion on proptosis, and today we'll be having a discussion on another important investigation in ophthalmology, corneal topography. So to discuss about it and teach us about corneal topography, we have expert faculty from across India. Gopal sir, can you please introduce the faculty?
Yeah, we have our own host faculty, Dr. Anil Radhakrishnan, who will be just giving a brief overview of corneal topography, how to go about describing it during your exams. And then we have very eminent Dr. Ritu Arora, who is Dean of MAMC at New Delhi. And then we have Dr. Srivalli from Shankar Netralaya to take us through this 1.5 hours of corneal topography. This will be a one-stop corneal topography for your exam. Don't miss it. Completely hear it. We will start up with a small presentation by Dr. Anil, followed by about 10 topographies being discussed, and then we'll finish up with the spotters by Dr. Srivalli. Over to you, Anil.
Yeah, okay.
I think all the postgraduates can actually open their videos so that when we answer, it will not be like ghosts talking to each other. Ankit, you can keep a few co-hosts so that if current issues or something like that comes in, then there will not be any problem in streaming.
Yeah, am I visible, Gopal?
Yes, Anil, please continue.
So, as Gopal told, I think it will be a very basic interpretation of corneal topography. I'll go through the motion of doing this to last for about 10 to 15 minutes. If I feel that I'm overdoing it, Gopal, please do feel free to stop me. So, if you look at this image, there is there are a series of buildings and the water there. This water body is reflecting the whatever is there in the foreground, just like a mirror. But if you see the image of this building and over here, the antennas and that metallic structures over there, these are not visible clearly. That is because of the imperfection in the water surface. So that is basically the principle of corneal topography. Is that the principle of topography or keratoscopy or keratometry is that cornea acts as a convex mirror. In this case, it's a plane mirror, but in the case of a cornea, it's a convex mirror. There is another caveat in that if you know the size of the image and size of the object, we can actually compute the regularity of the surface. You can get an approximate idea about the regularity of the surface. In the case of cornea, the thing is it's a convex mirror. So actually the irregularities are highlighted. That particular thing is utilized in corneal topography. So I'm not going to the history. Keratometry came all the way back in 1854. But the first video keratography actually came out only in late 90s. Actually, one of the earliest instruments I had the good fortune to use it, both TMS as well as the ISIS, while I was doing my post-graduation. The disadvantage of keratometry is that it measures only a very small area and it assumes that cornea is very symmetrical and it's a symmetrical spherocylinder. For that reason, it is not accurate for very flat or a very steep cornea. So this is a very basic machine that I have shown here. It's a TMS4. So you have something called which projects the rings onto the cornea, which is the data from it is captured by a computer and the printer is also there. So basically you have this 25 or more illuminated mice which are projected onto the cornea. And there are multiple video cameras which calculate the location of each particular point in relation to the central fixation point and compute it based on certain algorithms. So based on the algorithms, you get multiple images like this. This is a old TMS machine that is being shown. In that you can, the first thing that you should look at is the K1 and the K2 values. Ks and Kf it is shown here. Then the cylindrical value, Then there are two values called surface regularity index and surface asymmetry index. The importance of that has actually faded away with the emergence of new modalities. Still, I'll describe it in the later form. So what we normally see is the axial map or the axial curvature map or the standard map in which you basically that is accurate only in the central area. Beyond the central 3 millimeters of cornea, actually because of the oblique incidence of the rays, because the cornea, as you know, is the prolate surface. In the axial map, we assume that central cornea is flat. So beyond the central 2 millimeters, you have to factor in the incidence of the rays also. So you have to, this axial map will not work. So in the interest of time, and I think I want to keep this discussion more basic now, that's why I'm not going into many details of that. But you should understand that if you factor in that also, you get this refractive curvature map in which you apply the Snell's law also. Then there is something called the instantaneous curvature map also, which I'll come into. This is, for example, a patient who has undergone a laser procedure, LASIK, in which the central cornea, normally the central cornea is the steepest. This will correspond to around 45, anywhere between 40 to 45 diopters. But in this patient, because the laser has taken away the corneal tissue, the central cornea has become flat. And so the corneal values seem to be around 35.5, 37 like that. This is the axial curvature map. In the refractive power map, as you see, there is a blend zone. Beyond the area of ablation, there is a blend zone. And beyond that, there is a normal looking cornea. So this also is characterized. But in axial curvature map, you can just see the central ablation zone. While in instantaneous curvature map, there is another algorithm in which the point of each point is calculated, the fixation of the relation of each particular point is calculated to the nearby point. So compared to this point, this is flat, and compared to this point, this is steep. That's why this is shown as red. So these are basically used in research purposes, while axial curvature map is the one that is routinely used, while refractive or tangential curvature map is also used, especially to make out subtle corneal pathology. So it's very important that you keep the patient, the incident rays are perpendicular to the cornea. So you should have a minimum lid shadow. There should not be any dry spots. There should not be any pooling of tears. If you have dry spots, you can have appearances like this, which can actually be misleading. And if you have pooling of tears, you can see something like an inferior steepening, which again is an erroneous thing. And if you ask the patient, if the patient is not looking straight and is looking up, as I have done deliberately in this particular patient, you can see that the peripheral cornea is very flat. So this corneal abnormality is actually happening only because the patient is looking up. So in the absolute scale, you have these corneal dimensions anywhere between 35.5 to 50.5. There is a change of color happening at 1.5 diopters. Beyond that, it is happening at 5 diopters. There is also a normalized scale, which I'll come into later. Okay, so I'll just tell you about the normalized scale. See, this is absolute scale is made in such a way so that you can compare between the different topographers. Like the TMS4 and the ISIS, you can actually compare. While with the newer machines, in the Pentacam, the color change occurs in the central region at every 2 diopters. In Sirius, it is different. In newer imaging modalities, it's slightly different. So we cannot take this now, but this is something very important to look at the absolute scale. So what you call normalized scale is that whatever power is there in the cornea, that is divided into 11 equal steps, and then whatever colors are there is given. So I'll show an illustrative example. This is a normal axial curvature map. If you have a normalized this curvature map, you can see the blue colors, which suggests something like 37, 38 diopters. So whatever power is there in this particular cornea, from the steepest to the flattest, is shown. So I will not go into these details. I will just tell that these are the normal corneal patterns that we see in a routine case. So you can have a round pattern in which the central cornea is steeper and towards the periphery there is flatter. There is a very small amount of astigmatism, somewhere around 1 diopter or less than that, you can have an oval pattern. There can be a superior steep, an inferior steep. Quite often you get the irregular pattern, which is seen in about 12 to 15% of cases, which is perfectly normal. Then these are the important things. A lot of these people can have asymmetric bow tie. When you have astigmatism, normally you have two bows of the tie which are symmetric and in one line. While sometimes it can be slightly asymmetric when we call it an asymmetric bow tie pattern. So if the larger part of the bow is down, you call it asymmetric bow tie with inferior steepening. If this is up, you call it asymmetric bow tie with superior steepening. Then there is something called skewing of radial axis. Normally, both the bows of the tie are in one line, but if there is an angle between these two, or you call it the skewing of radial axis. I'll show some illustrative examples. This is an oval pattern, almost becoming a symmetric bow tie pattern. It's perfectly normal. If you see the K1, K2 values, it's perfectly normal. Astigmatism is normal. The important thing is you should look at the color corresponding, whichever map it is, you should not just look at the color and just say, you should see this color in relation to the color table over here. This is like something like a grayscale in a visual field. So you should not really too much depend on it. You should really look at the numerical values. So this value is corresponding somewhere around 44, 45, and this is seen to be perfectly normal. So this is a superior steep pattern in which you can see that two bows of the tie are there, in which one is much more larger than the other one. But if you look at the K1 and K2 values, it's perfectly normal. Cylindrical value is normal. Surface regularity index and asymmetry index is normal. And if you look at the value over here, it is also coming to just above 47, which can be really taken as normal. So these are certain astigmatic patterns that we see. This is the symmetric bow tie I was talking about, two bows of the tie. This can be with the rule or against the rule. With the rule means it is the red color is actually facing vertically. So it need not be exactly vertical. You call it a with the rule astigmatism when it is within 30 degrees of the 90-degree axis. For example, anywhere between 60 to 120, you call it with the rule. So also against the rule. So if it is directly like this, it is called an oblique pattern. This is the skewing of radial axis I was talking about, the asymmetric bow tie. Both the bows of the tie are in one line. If this is like that, this is most likely normal. But if there is a angle between the two, you call it a skewing of radial axis. Mild skewing, a few degrees may be normal, maybe a normal variant. But if it is more than, say, 20 degrees, it is definitely pathological. And this is a typical early keratoconus. In contrast to this, this is my own topography in which I have astigmatism. So there is a symmetrical bow tie pattern. The way you look at it is you should look at the K values, then look at the astigmatism, which is about 3.39 in the cornea, and look at the steepest value over here. It is coming to around 48 or so. So all these parameters are well within normal limits. This you can call it an irregular pattern. What about this? In this, there is a localized steepening. So how does that happen? When you have a localized steepening like this, you should go back to your ring images and see whether there is an imperfection over here. You ask the patient to blink a few times and take the picture again, and you get a perfect early symmetric bow tie pattern. So I will go to keratoconus now, which is the most important one, which is necessary to be distinguished. So classically, you have this asymmetric bow tie pattern with skewing of radial axis and asymmetric bow tie with inferior steepening. This I'm telling about the classic things. There are various other subtle parameters which we can talk about. So when you interpret the topography, you can say that you just look at the K values. This K flat is seen to be 43, while the K steep is seen to be 54. The cylinder is seen to be how much? Around 9 diopters or so. You look at the surface regularity index and the asymmetry index, it's way high. Usually there will be a mirror image symmetry in the other eye also. Even though there is no keratoconus, you can see that this area, there is some amount of steepening. This value would correspond to somewhere around 47.5, but still it is only localized to the inferior part. And interestingly, surface asymmetry index is increased in contrast to this, which I showed before. So there is something called a Rabinowitz criteria, in which basically when you have a keratometry more than 47.2, inferior, superior at the 3 millimeter area, if there is a difference of more than 1.42. So I'll just explain that. If this is 3 millimeter, between this, sorry, can you see the cursor here? if you look at the value here and here, this should be almost normal. Small changes are okay. Up to 1.26 can be considered normal. If it is way beyond that, it is abnormal. It happens only in a asymmetric cornea. And if there is a skewing of radial axis more than 21 degrees, again, an indicator of keratoconus. And another indicator is the SIMK value difference more than 1.5 diopters between the two. So I think in the interest of time, I will not go into these details. But this is something very, very important. Even with the regular topography machine, you'll be able to see that at 3 millimeter area, you should look at this point and see the difference between the two. So as I said before, up to 1.26 can be normal. Once it crosses 1.4 to 1.8, it is taken as suspect, and more than 1.8 usually is keratoconus. So there are various other indicators which is there in the pentacam also, which I think in the way we will discuss. So this is a image, this is a topography. On top of it, there is a tomography also. In this, you have a, as I said before, there is an asymmetric bow tie pattern, very suggestive of keratoconus. If you look at the pachymetry map, within the central 3 millimeters, there is a lot of crowding of colors. More than 3 colors are there within the central 3 millimeters. See, this corresponds to the pupillary area, and one of this will correspond to 1 millimeter. So 3 millimeter area will be somewhere around this. So I think within that area, there is more than 3 color changes, which is suggestive of a abrupt change in the corneal curvature, which is suggestive of keratoconus. Then there is a relative pachymetry map in which you can see a there is some crowding of colors over here. The other, like if it is up to 9% can be considered, 9 to 12% is suspect, more than 12% is usually suggestive of pathology. So there is the anterior elevation map and the posterior elevation map. Anterior elevation map in which this should be about 10 diopters or 12 diopters. If it is more than 15 diopters, it is pathological. Same way with the posterior elevation map. If it crosses 12 microns, it is suspect. And if it crosses 15 microns, just like in pentacam, it is suspicious. It is suggestive of keratoconus. So this is a patient again with keratoconus. I will not go into this. There are different software criteria based on which also you can make the diagnosis, which are there in multiple machines. So I'll just tell about cataract surgery also. Before cataract surgery, it's very important to do topography, especially when the patient is opting for a premium IOL. If you have a cornea like this, can you think of a premium IOL? What I meant to say, multifocal IOL. See the difference in K between here and here. Here it is corresponding to somewhere around 49. Here it is maybe 44.5. Here it is 37. Here it is 44. So there are a lot of multifocality of the cornea is already existing. So multifocal will not work properly in such a scenario. While in this patient has a symmetric bow tie pattern and a regular astigmatism. So in this, it should work. So also, like in a toric IOL also, you should look into this. This is a very symmetric bow tie pattern. So multifocal or toric will work in this patient. While in this patient, you can see that some part it is much more than the other. So multifocal IOL is not a good choice. Even toric, it will be, it may not give the best possible results. But this patient has undergone a keratoplasty and has a high degree of astigmatism after oral suture removal. You have a situation like this. It's a somewhat symmetric astigmatism. You can take the patient for a toric IOL. So in this is another scenario. This is a patient who has undergone a refractive surgery. You can see that this area is blue in color.
Anil,
yeah.
Your cursor is not clearly seen in the video. Can you show once again? Can you show slowly cursor?
Yeah, I'm showing it now.
The mouse we are not seeing. So when you say here and there, we are not seeing actually.
Okay, fine. Okay, fine. So this is a descended ablation. You can see that in the central circle, one part it is blue, one part it is green in color. So it is a descended ablation in contrast to the other image in which you have a blue image all around. Okay. I think it is more than 15 minutes, so I won't go much into the details. Only thing is, I'll just tell about the tomography also. So this is basically about the topography. And in the late 90s, we had this OB scan, which basically looked at the corneal tomography also. Tomography means just like a CT scan, you have the section of the eye also. So basically, OpScan was the first device in which it was seen. It was a scanning slit technology which was used. So basically, it will get multiple slices of the cornea like this from limbus to limbus, and then it reconstructs an image like this. So in this, there is a concept called best fit sphere, in which if you see this watermelon, you can see that it is beautifully peeled off. The shell is separated from the pulp. So this exactly fits onto this. So this is a perfect fit. But a cornea is actually a prolate shaped one. So it will not fit. If you think that this is a conical structure and you keep this shell over here, what will happen? The conical part will project above that surface. So that will be seen as red. While in these areas, in the mid-peripheral areas, it will be short of it. So that will be seen as blue. I'll show in the image over here. In the first image that you see on the left-hand side, you can see that this there is a central area which is corresponding to the red color. In the mid-periphery, you have a blue color. And actually, you have extreme periphery also, you again have red color. So this is the image of a OpScan. So in this is the axial curvature map. Whatever I said before, K1, K2, astigmatism, asymmetric bow tie, all this applies here. This gives additional information, whether the anterior best fit flow sphere is, how much elevation is there. So also for the posterior surface. And this tells you about the corneal thickness map. So when there is a localized change in the corneal thickness, it will be able to see. So Pendacam, I think Srivali will be going into that later. So Pendacam, it refined OpScan data even further. In those also, if you see that the anterior elevation is seen, if it is up to 12 microns, it is normal. Once it is more than 15 microns, you call it as abnormal. And then posterior elevation in a best fit sphere, if it is 5 microns or more, you should consider it as abnormal. But practically more than 12 microns only, we take it as abnormal. So briefly about tomography, first thing is the OpScan, which was based on scanning slit technology. Then came the Scheimpflug system, in which there is something called a Pendacam. Then there are modifications of that. There's a dual Scheimpflug which is utilized in Galilei as well as Sirius. Then Galilei had the bright idea of combining Scheimpflug along with the Placido, because Placido is very sensitive. So they got this Galilei G4. They incorporated OCT also into that, and they called it Galilei G6. And even the Schwinn series uses similar technology. Because OCT is something sensitive to look at the corneal thickness, there is Placido plus OCT can also be utilized. But in our hospital, what we have is the Visante Omni system, which uses the time domain OCT. The newer modifications is the SSOCT, in which CSO MS39, which is marketed by the Schwinn, and Heidelberg has brought out the Anterior on, which is pretty expensive now. So what it does is you get a good Placido disc elevation, then you add the pachymetry data, and then you get the posterior. So the Atlas topography will tell you the anterior elevation, then accurately the corneal thickness is mapped out, and from that you deduce the corneal thickness, the corneal curvature and the elevation. And then you get a printout like this. Okay, so in addition, you can get certain OCT images also. So the OCT is slightly more accurate than OpScan, especially in highly distorted corneas. For example, this is a patient with keratoconus who was actually it is obvious for you, this is coming to more than 60 microns. This is coming to more than 75 microns. The K1, K2 values are 62 and 70 plus. Then if you look at the pachymetry here, this is seen to be, thinnest point is seen to be 329 microns. So this patient came for a second opinion. We did an ultrasound pachymetry in which we found that it is around 400 microns. And we did an OCT. This also showed around 400 to 410 microns. This is suggestive of, as you see here, you can see the curvature data, the colors corresponding to say 58 or more than that. Then pachymetry values, crowding of colors, both in pachymetry map as well as relative pachymetry map. Anterior elevation more than say 50 microns. Posterior elevation again more than 60 or 70 microns. Everything suggestive of keratoconus. I will, in the interest of time, I will conclude it now. I think we'll go to cases. Amrita, I'll unshare my screen now. And
Yeah,
Amrita.
I have unshared it, Anil.
Yes, sir. I'll share my screen.
So how many cases do we have, Amrita?
Close to 30, sir.
Oh, 30.
Yes, sir.
Oh. Somebody told me 10, 8. Anil told me 8.
Some of them are two eyes of the same patient. Gopal.
Oh,
Yes,
my
sir.
God.
Okay. Now you go to the first case, no, Amrita?
Yes, sir. This is the first one, sir.
Yeah. So,
So, shall I start, sir?
yeah, please start.
Just 1 minute. If you just give me 1 minute, can I
Yes.
speak something?
Yes, ma'am, please.
Sure,
Yeah.
ma'am.
So I do not know what is the level of the postgraduates. Are they first year, second year, third year, or they
We
can
have
be-
first years as well as second years, ma'am, in this.
So, and I'm not sure how much exposure they have to topographies. So can we just have first one run through that? Suppose a postgraduate is shown one topography, that how he has to go about describing it.
Yeah.
And then if we go about the application of the same as to who's presenting, sorry, Amrita. Yeah.
Yes.
So application of that to this. I don't know if that's my idea. Because they are very new, these first years and second years. So I would probably go by that. Maybe if you have some pentacam or op scan to show to begin with,
Yes, ma'am.
so that just why don't you start with pentacam and op scan, and then all the postgraduates I can request that please have your videos on and let's be very open. Let's discuss it threadbare. Don't feel scared. It's better to clear our doubts. Even I'll clear my doubts over here. I don't know. How do you feel, Gopal and Anil?
Absolutely, ma'am. The stage is yours.
Yeah, that's my way of reacting, I mean, just being with these children because they're very new. So if you have any op scan or any pentacam.
Yeah, fine, ma'am. Amrita, can you leave the presentation? I'll put some presentation.
Yes, sir.
Yeah. And then maybe we can have one postgraduate, any postgraduate can volunteer and describe, how they would go about it. And then maybe we go on to that. Because they are very new, at least the PGs from my hospital have joined. Some only have 1 month exposure, while others are like 2 years old. But just to go about how in exam and how critically we would examine every op scan.
Anil, Srivalli was showing some pentacams. No, she had some pentacams. You have to take it. You have to search it and take it, or you have
it is there, Gopal. It is there.
Okay.
I can get it.
It just have one routine, normal,
Sure.
slightly abnormal, so that they know these are the things they have to specify. And I would just request all the postgraduates, just don't be shy, just feel free to, we're not judging anyone. Yeah. So this is the first one. Yes,
Yeah.
Who's presenting this? Amrita or Anil? Who's presenting?
Amrita.
Amrita. So Amrita, then why don't you take the lead, and suppose you are given this pentacam, how would you go about describing this pentacam?
Yeah. Ritu ma'am, we
Yes.
don't have pentacam here, so I think
No, there is, this is a
they will do
pentacam.
it.
Isn't this the pentacam?
Yeah.
What she has presented. Oh, so you mean that you don't have the pentacam at your center?
Yeah.
Is that what you're saying?
Yes, ma'am.
Okay.
But she'll do it. I think.
Yeah,
let's-
if she can do it, and maybe if some of my postgraduates, if they can volunteer. Yeah, let's see, Amrita. Don't feel shy, because you may be at some other center or in an exam, you might get pentacam and you may not get what you were showing.
Yes, sir.
Yeah, it's okay. Absolutely okay. Please go about.
Amrita, you can remove your mask.
Yeah. Maybe all this Ruchi and Meghna, Shilpa, I mean, these are my postgraduates. I mean, others are very fresh. So please volunteer and see how you're going to describe or study. This is like this pentacam. I don't know whether it's normal or abnormal. We'll derive the conclusion afterwards.
Yes, ma'am. Should I volunteer, ma'am?
Yeah, who's that? Meghna.
Yes, ma'am.
Amrita, you want to start? Otherwise, maybe somebody else could do it. I mean, let's see, but let's give Amrita a chance because she's projecting.
Okay. Yes, ma'am. Yes, ma'am.
Yes, Amrita,
Okay.
start.
This is the pentagram image of a patient's right eye.
Right.
Coming to the parameters.
Uh-huh.
K1 is 43.4 diopters.
Okay.
K2 is 44.1.
Mm-hmm.
Then the K mean is 43.
Do you have a cursor? Can you take your cursor along with it? Because I know then it becomes easier. Okay. Because they should know where to look for it. Okay, good. You're doing good. Yeah. Please continue.
Astigmatism of 0.7 diopter.
Okay.
And we need to look at the Q value as well as the quality specification.
Very nice.
Okay.
I'm so glad you're talking about it. Can all see what is written QS? There's something written QS and Q value. Can you all see that?
Yes, ma'am.
At least have your something so that I should know. I'm not talking to the ghost. Gopal has already talked about it. So what does QS stand for?
Quality score, ma'am.
Okay, so quality score, what is it telling you? It's okay, which means it is a reliable. It's a reliable pentagram. Okay. Then what is Q value telling you? Yes, Amrita.
The asphericity.
Very good. Degree of asphericity. And what is the normal value you will take here? Degree of asphericity.
-2 to -3 can be considered.
-2. No.
Sorry, -0.2 to -0.3 usually in normal individuals.
No, up to what is the range beyond which you will start considering it's abnormal? Anybody?
If it is
more than 1 is abnormal.
So this is actually quality value should be between 0 to -1.
-1.
Okay, because this is a prolate cornea, and I hope you understand what is prolate cornea. Okay.
Yes.
So it should be between 0 to -1, and it's only when it goes on the positive side that would indicate that what would that indicate?
A post-ablative statement if it is more than 0.
Yeah, so exactly, very good. So if you get here the value which is say 1 or 2, so which means you're dealing with an oblate cornea. So sometimes we are at loss as sometimes to know whether the pentagram I'm dealing is post-ablated cornea or not, right? But in post-ablation also, it only picks up if you have ablated more than 3 diopters. Okay. And if it is more than on the -1, more on the minus side, what does that mean?
An ectatic hypoprolate.
Hyperprolate cornea. It's a hyperprolate cornea. And when do you see hyperprolate cornea?
In ectatic diseases?
No. Yeah, maybe you are right. Yes, it increases, but more specifically, suppose it's not ectatic. If you see it post hypermetropic LASIK, right? Post hypermetropic ablation. Okay, get it? In post hypermetropic ablation also the central area becomes steep. So there also this will become more on the -1 side. Okay, please carry on. Now tell me. So these are the things which you have to start with. Say it's a quad map showing axial, elevation front, elevation back, and the corneal thickness. And then you say whatever you said just now about K1, K2, steep K, flat K. Say it's a reliable quad map with Q value, which is this, which is, again, please be very specific. It is giving you within the area of 8 mm asphericity. Can you see that? It's written over there.
Yes, ma'am.
Okay. Yes, carry on, please. What else you want to tell me in this?
Then the thinnest
Uh-huh.
Pachymetry at the apex is 562 microns and thinnest location is 557 microns.
Mm-hmm.
And K max is 44.4 diopters.
Mm-hmm. What is this X and Y written in front of it?
The axis, where
So
it
it's
is.
just telling you the coordinates. If you
The
have to
coordinates.
locate it,
Yes.
right? Okay. And you will see in the sagittal curvature map, there is a small, just below the center, towards 7 o'clock, there's a small circle.
Yes, ma'am.
Can you see that?
Yes, ma'am.
Right? Any relevance of this? Anybody?
And the pupillary center.
No, that's not the pupillary center. You see a small circle in the 7 o'clock area. See now, because you won't be able to see my cursor. You see the center, and if you'll just see in the 7 o'clock within the 3 mm circle. Are you
Yes,
seeing?
ma'am. Ma'am, the small circle,
Huh.
the round one. Ma'am,
Yeah.
it basically it shows the fixation of the patient.
No, you mean patient is fixating downwards?
Ma'am, the point where we want to elicit a hotspot.
No, you see here in the Pachy part, when you see thinnest local. Are you seeing thinnest local there? You see a circle there also.
Yes, ma'am. Yes.
Okay. So this is the area which is actually this should be more relevant. I should have pointed out here in the corneal thickness, but it's not so evident there. Therefore, I went over there. Okay.
Okay.
So this is the area which is telling you the local thinnest area, which is in this part. Okay. And usually it comes, you can see here in elevation back also. You can see this small circle here. Elevation front also.
Madam, again, I think your cursor is not seen.
Yeah, my cursor is not seen because I'm not the host.
Presentation is done by Anil.
Yeah.
Okay, I can. Is my cursor seen, Gopal?
No, I can't see your cursor also.
Yeah, somehow we are not able to see the cursor.
See,
Anyway.
if you see whatever is a circle written in front of thinnest local, can you see that? Can you see in the thinnest local on the left side, there's a small circle written next to 557. Isn't it there?
Yes, ma'am.
So now this circle is there in all the maps. All the maps, this circle is there. Okay, anyway, so let me not sit on it. So, and then another important thing to see out here is when you're seeing elevation front and elevation back, please look at the dia which is written over here. Dia means that it has collected the data from 8 mm or, like it's 8 mm elevation back. If you're comparing, suppose this patient comes later to you with another same pentacam 6 months down the line, and somebody has not corrected it, and then the dia might be 9 mm there. The values will change. You cannot compare. So you need to compare, just check the dia, what is written on the top of it. And also what Dr. Anil talked about, that more than 8 microns becomes abnormal elevation. That is when the dia is 8 mm. Okay. And out here he's written best fit sphere 7.73 is millimeter and best fit sphere elevation back is 6.35. So these are certain things which you have to see, and you cannot interchange from one to another. And also down below you will see it's written here 0, 4, 8 like that, So it is telling you that within 2 millimeters of the cornea, 4 mm of the cornea, 6 mm of the cornea, like that, how the mapping is done. Okay. And in elevation front, it is just telling you how much it is elevated above the flat surface. So you will see it's written +1, 0. So it's by and large a little flatter cornea, it's not elevated too much. And you're getting the K as 43 only. While what are you getting over here? You're getting on the edges blue, which means, what does it mean? Anybody? What does that mean if you get a blue color here?
It's flatter than the.
Flatter,
10 बार तुमको समझाया है, 10 बार समझाया है कि this is an elevation map. You cannot use the word flatter. Flatter is a word to be used for curvature. This is depressed below the normal. This is only telling you how much elevated a particular thing is above the level. It's like, If in Delhi, we are at the ground level, okay? You go Bombay, below sea level, it is below, depressed. While if you go towards, from here, with respect to Delhi, this is with respect to something. So it is with respect to the flat, this is depressed, okay? Which is normal, okay? So same thing, this is of course very much normal map, which they have tried to show. Now with respect to this, now better you go on to and show your other maps. If anybody is not clear, we can, we can't spend more time. Let's go more over to other maps now. Yes, Amrita.
Yeah, can I ask one question? What is the normal y coordinate? Any of the postgraduates? Madam was telling about the y coordinate shift, no? What is the normal range, and above which level should you consider it as abnormal?
It's less than 5 mm, 0.5 mm, sir. It's normal.
What is it here in this?
.5. No, 0.71. sir.
0.71. Okay, fine. Okay.
This means that how much deviated it is from the central area.
Center of the.
Okay, so normally up to what she said, right? 0.5 mm deviation is allowed, but this is 0.7, is slightly more.
Slightly.
That one parameter will not say that this is keratoconus.
Yeah, that is true.
Okay, so you have to have a lot of other things. Yes. Anybody wants to take the lead in describing this bad? We're not involving, what's the name from the lady from Shankar Netralaya?
Yeah, good evening, ma'am. I'm Dr. Srivalli here.
Yeah, sorry. Yeah, we've
Yeah.
not met. Yeah.
Yeah,
So
hi.
maybe you could also now involve them.
Yeah. Thanks, ma'am. In fact, I'm also learning as you're teaching. It's good to hear you. I just wanted to say, along with all the things which ma'am has said, can you just go back to one slide back, and the same. So when all of you are starting, just please make sure that you're looking at the date of birth which has been entered there. Okay, and then see what is the age of the patient, because all these normalized values, when we are saying, the comparison is happening with the normal of those age groups.
Yeah.
So whenever you are reading out a quad map in an exam, so it gives you a little more time also. You can say this is the quad map of the right eye of and look at the age and say that of a so and so aged person. So that will again start telling you what is it that you are looking at. Because if it's a 10-year-old or a 30-year-old or a 50-year-old, again, the ectasias which happen or what is the thing most likely also will start coming into your mind. So that would give you a clue as to what could be the diagnosis, because the age also will come into play. So that was just a pointer, and rest of the things ma'am has beautifully explained. So each of these box, like the first box, second, third, fourth, so go step by step in that.
And it's a common mistake for people to use blue as, flatter curvature. So please always say that it is elevation or depressed map, and don't use a curvature word over there. Yes.
Yeah.
You want to take on this bad map? Really?
Yeah, Amrita, are you going to?
I think because we don't have Pentacam, I don't think she may not be in a position to do it.
Okay.
One of your postgraduates,
Okay.
ma'am?
Yes, anybody?
Ma'am, should I describe, ma'am?
Yes, please.
Yes. Ma'am, first
Meghna, can you
we'll,
on your video, please?
yes, sir.
Meghna, you using your iPhone? Can you see that in your the values in your iPhone?
Yes, sir. Yes, sir.
They are working with 6x4 vision or 6x3 vision. Yeah.
At least when you come for these classes, it would be better to use a laptop and see. At least probably she's on a tablet, not on a phone. Is it?
No, sir. I'm on my phone, sir.
Chalo, she's honest. Let's go.
Okay.
Yes, describe.
Ma'am, in this map, we look at the Bell and Ambrosio displays. Ma'am, the first one is the normal Bellin-Ambrosio display. The second one is the enhanced display, in which basically the elevated area is subtracted from the normal bad display. So it further enhances the difference between the elevated area and the conic keratoconic area. And so if we look at the bad value, it is 0.69 in this. Ma'am, less than 1.7 is normal. 1.7 to 2.7 is the suspect, and more than 2.7 is keratoconus. And
so
then,
bad, you're right. The idea behind it, Meghna is on the right track. So here, when she said first and second, we are talking about it vertical, right? Or here it is elevation front on the left side. Next to it is elevation back, right?
Yes.
And
Yes.
within this, that's what you have to describe. So here the top is like normal. If anybody was, yes, somebody saying something? Yeah. So this is the normal. Again, this is not the curvature. This is telling you just the elevation on the front, right? But at times when you're borderline, so it just takes the area which is the thinnest area, basically where the pachy was thinnest, and 3 millimeter circle around that. Total circle is 3 millimeter. So data from this is excluded to come to this second map, vertically second map, left side. Okay. And the last map is the difference on the front. Okay. And on the right side, similar thing on the back side. Okay. I'm not discussing the logic behind it, why Bellin came up with that. Otherwise, we'll spend a lot of time. You can look it up. Why he has come up with this idea. And that is what has come down below. Can we just raise it a little bit? That the elevation, which he says green, less than 5 micron, 5 to 7, yellow is probable, and red means definite conus. No. Same.
I can't do it.
Okay, baby, it's okay. It's fine. It's fine. So this is the idea of bad. Then there's another thing which is on the right side. What is this? Corneal thickness spatial profile. And percentage thickness increase. Okay. And what are these 3 lines drawn in that?
Ma'am, basically it gives the progression of the thickness. Like the cornea is the thinnest in the center, and the line we can see it is going. The thickness is 500, around 500 in the center, and it's increasing in the periphery. So it's a normal cornea. And the lines we
what
can
I'm
see.
trying to say is, what are these 2 lines? You have 3 lines, dotted lines.
Ma'am, yes, standard deviation.
Plus minus 2.
These are the standard deviations for whatever is the normal. And red is the one which is traced for this patient.
Yes.
Okay. So if it is following within this normal curvature, normal line, and this, then it is coming to be
normal cornea.
Normal cornea. And you also have to look at, these are the statistical indices given. Though these are different parameters, statistical indices given as to how much deviated the thinnest area is from the normal population. What is the highest, those different things are there. And how much deviated it is from the central area deviation. Then what is the back curvature like? So every deviation is scored, and this is the final probability given that whether this patient has keratoconus score or not. So here he says that D value is coming to 0.69. This patient does not have any chance to be having a keratoconus. Okay. So, I've just given a very bird's eye view. You need to go into detail to really understand all this. Yeah, you want to add anything, Srivali?
Yeah.
Thanks, ma'am. So, along with all the other things that ma'am has just told, just to explain this once again, it's like zooming into one particular area. It's like students are there, 10 students, and if 8, 9 of them are getting, 60%, and one of them gets 99%, if you just take an average, then you are actually missing to see that who has got the higher score, right? So you want to see that one person who has got a higher score. It's like that ecstatic point. So if you just exclude that one person's score and take the rest of the average and then see, and then that person's score would stand out. You understand? So it's that way of just doing that. And again, another easy thing for you to see is that all these indicators, the QS value and the scores below, whatever is given. So see the color of the box. So if it is a normal, then it will be showing you in white background. If it is borderline, it shows in a yellow background. And if it is in the red, then definitely it's abnormal. So that's the color coding already given below all the three, circles which are there. And the same now, when you come to the right side and look at the differential scores, these are the differential scores. So the differential score of the front, the back, DF is front, DB is back, DP is pachy, D and TH is the thinnest value, and the next one is the Y meridian, the X-axis, the Y meridian of the thinnest location, and then the overall D. So again, everything is in white. So white background. So even if you don't remember the whole score part of it, if you don't remember the 0.69 or whatever is the thing, just see that thing and overall you can say this is a normal scan. So that much you should be able to explain.
Okay.
At times, these become very important because patients are, when they are screened before refractive surgery, So if any point comes yellow at times, you have to be cautious whether this patient should be taken up for refractive surgery or not. But having a single point yellow, that doesn't have much significance. Okay. Like today only, if somebody sent me one pentagram, which was of a 21-year-old lady gone for refractive surgery. I wish I could project that. And it has absolutely regular astigmatism, 3 diopter regular, symmetrical, bow tie, 44 and 47, like that. Thinnest pachy is 523. But one of the thing, I don't know, back or something is yellow. So the person was a little cautious, whether I should do refractive surgery in this patient. But those things will not apply to an astigmatic cornea. Right? Yes.
Yeah.
Now maybe we can go to.
Yeah. Just to add one more point, ma'am, the PTI also, the normal range, I just want to say that it is between 0.8 to 1.1. So as you see in the particular case over here, the average values seem to be 0.93, which is perfectly within normal limits. The minimum value is 0.60 and the maximum value is 1.37.
See where the progression index is written. I mean, since the cursor is not there, just above the map, you should see where progression index. That's what Dr. Anil is trying to tell you. And average, what did you say was what?
0.8 to 1.1.
Yeah. So here it is 0.93. So it's very much within normal. I mean, average minimum is 0.6. So it's very much within normal. Okay. This is another one you're showing?
Yeah, another one, ma'am. Another one.
Yeah. Now, who volunteers to describe this?
Now, somebody else just start and do the same thing what the other PG has done. And let's go fast so that we can see more scans.
Yes. Yeah. Yes.
Lisa, can you do it?
Apply the principle, what we've talked about. That's why I devoted more time on that.
Okay. So this is a pentagram image of left eye with the date of birth is showing 1998. So probably a 22-year-old person, 24-year-old, with the K1 value of 43.9 and K2 44.3 diopter, with the Kmax of 44.1 and the astigmatism of 0.4 diopter. With the QS is showing okay and Q value is minus 0.27. Moving on to the axial or the sagittal curvature, it is showing 44 around the central area is showing around 44.
pattern.
With the elevation moving on to the elevation map, which is showing a superior and inferior depression. And the corneal thickness map, which is showing around 590. And the thinnest local is X value is around 0.56 plus 0.56 and Y is showing minus 0.63.
What is this?
As you keep reading, just tell your inference also.
Yes, that's more
Because if you just read out what is there, then the examiner is going to ask you further, so what?
So what? This anybody will read out.
Yeah.
Anybody will read it out. Yeah.
So you say the QS value is showing okay and the Q value is minus 0.27, which tells us that it has been recorded well. It's a well recorded data and it's a normal cornea with a normal asphericity. So you keep on adding your point to that. Okay, Elisa?
Yes, sir. Yes, ma'am.
Yeah.
That is within the norm.
Yeah, so you say that.
Yes, ma'am. Then
and so each of the quad map also. So this is a fairly regular looking cornea with a, maybe with the rule astigmatism, roughly a little bit.
Yes, ma'am.
Yeah.
Why are you getting this bean-shaped thing? What is this bean-shaped thing? You're getting that bean, no?
Yes, ma'am. That is in the corneal. Yeah, it's there in all the maps.
There in all the maps. What does it mean? Is it some kind of a pupil dilatation, Anna? With some posterior synechiae? What is irregular pupil dilatation? What is this?
Yeah, I am not sure, ma'am. I think it is pupillary marking only, no?
Yeah, no? Because normally pupil marking comes in all and normal comes circle. And here it is coming little eccentric and irregular. Either this patient had some kind of posterior synechiae or what.
Maybe it is partly dilated while preparing for refractive surgery. Maybe it was repeated or something.
Yeah, because here the question would be this. Rest whatever you said is okay. And what is the central elevation you're seeing over there? Max elevation. What's written over there? That's something where you have to concentrate. How much is the elevation coming there? Is for plus what? 11? Is it what? Is it plus 11? What is it, Anil? Central green elevation plus?
1 plus 4 plus 4.
Plus 4.
Plus 4. Okay. So
Yeah,
it's normal? Anything to be given any importance weightage to that?
No, ma'am, it's normal.
Okay. 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 And just look at dia what is given. So just compare those things. Yeah.
This is the bad display. Yeah.
Yeah, so this continue because it's obviously the same patient with the bad display.
Okay, there's nothing obvious, So you'll see it's all green here. I'm just quickly going over it. Okay, I've already described you the basics. And then you see the progression index. Progression index is 0.61, average is 0.9. So it is again within normal range. Okay, and see where your PTI and CTSP is falling, again within the normal range. And you look at the reference database down below, again it is, no color. So
background is like.
Yeah, so it is normal. Cornea-wise normal. Okay, rest we don't know what this patient has got, but cornea-wise normal cornea. Yeah. You have some abnormal corneas coming.
Yes, ma'am.
Huh? Uh-huh.
Yeah. This one.
Uh-huh.
Can you, Ishwardhan?
Yes, sir. So this is a pentacam quad map of a patient with the right eye being recorded or being examined in this particular image. The K1 value mentioned here is 45.6 diopters and K2 value is 47.3 diopter, which is again towards more of a steeper side. KM is 46.4 diopter. QS is okay, and Q value is minus 0.4. So it's a decently recorded study. Coming to the axial sagittal curvature front, we are seeing yellowish coloration covering over the entire area of the study, which is pointing towards more of a 46 to 47 diopter range vertically, and horizontally it is about 45 diopter. So I would infer from this that this is more of a with the rule astigmatism, and since the steep axis is at 90 degree, at least in the central 3 millimeter area. Then going to the
Can you give me one answer why it is uniformly yellow in the curvature map? You have how come there's no blue, there's no green, there's nothing, no red? Why it is uniformly yellow? Though you're seeing a lot of variation, you're seeing variation 45.8, 45.4, 48. You know, there is a variation of K if you look at it in the central 3 mm,
yes,
right? But color, if suppose you were to go by color, you'll say, yeah, it's fairly regular. Anybody can answer that question, why we are seeing uniformly yellow? Come on. Anil talked about it in the scale. If you really see on the left side,
yes, ma'am. The thing is, yes, ma'am. The thing is that the scale is varying from 2 diopter.
Yes,
range.
so there is a wide variation.
All the values
Wide
are within this given range. Yes.
Yeah, you'll see it's within 2 diopters. Yes, while above, of course, it is 10 diopters on those colors, right?
Yes,
so if the variation is within 2 diopters, it's going to show you the same color.
Yes, ma'am.
While if you have the variation, so always before you interpret it, look at the scale. If the variation is within 0.5, it will magnify even a small difference. Okay? Yeah.
Yes, okay. Then coming to the corneal thickness map, the Paki minimum shown here is 510 microns, which is fairly within the normal limits. And the cornea is of the same thickness in at least in the central 3 millimeter, and the progression further on is fairly what is supposed to be normal and towards the periphery as well. And then coming to the elevation front map, the diameter is of 8 millimeter here, and there is depression seen in superiorly as well as inferiorly in the front elevation
when
map.
you see, I always tell my PGs, if you see an elevation map like this on the front top right, depression blue like this and central, suppose it was a little more green, what do you infer out of that? What kind of a meridian you're getting over there?
Okay, so for elevation, basically we are comparing the elevation, the front surface with the regular surface, which we are considering as normal, and then we are trying to see how much is it differing. So what
No. Here, what I'm trying to say is, in your mind, if I have to make up, if I just look at the elevation map, it tells you something like, if you really see my hand, you know, center is elevated, periphery is depressed.
Depressed, yes, ma'am.
Right? Normal cornea should have been like this. Okay?
Yes,
normal cornea should have been like this. But what you're getting is like this. It is depressed below, which means that this meridian is steep.
Steep.
Okay?
Yes,
you can also go and see, check it from there. That what are you getting? This K2, whatever. You see on the left side where these cornea front is written, you see that red color. You see the red steep is vertical.
Yes, ma'am.
Okay, so with this, you can actually now understand what I'm trying to tell you, the importance of steep. Okay, so this is telling you that this is definitely having an astig. If I look at the curvature map and just go by the colors, I may think there is not much of astigmatism. Okay, but if I really see the parameters, what is the astigmatism coming to? 1.7 diopters.
Yes, ma'am.
So it's close to 2 diopter astigmatism. So it is not something that we
significant.
can ignore.
Yes, ma'am.
Okay, so it becomes important. And that this elevation map is heightening it.
Yes, ma'am. That is what the elevation map is basically comparing the patient's anterior surface with the normalized thing, and then
Yes.
saying that it is something like this. This is the normal,
Yes.
and this is the patient's. So this part is looking depressed, and the central portion is in contact with the normal.
And what is the central elevation? What is the figure? I can't read it. What is the central elevation written
It's
over there? 33?
2.2.
What is it written?
Anil, you can zoom it on your screen. You are
Anil, you can read it out for us.
22 micron, I guess.
It's written 22. Okay. Okay. And the
No.
posterior? Posterior central is 11 or what is it?
Minus 14 or
Minus,
minus 11.
minus 40.
Minus, I'm not able to see that. It's a bit.
No, it is, I think, 2.2 and other
2.2.
one.
Yeah.
Yeah.
Plus
The
2.
other one is
This,
Yeah.
I think it is shown as, I can't, there is some overlap there, man. I
Okay.
can't exactly read it. It is one or.
So by and large, what is the inference coming out of this quad map?
with the rule astigmatism
With the rule and a thin cornea. Don't
and a
miss
thin
it
cornea.
out.
Yes, ma'am.
The local thin is coming 508.
5.
Okay.
Yes, ma'am.
Now, K max, look at it. What is the K max?
46.5 diopter.
No. That is not K max.
A mean.
Okay,
K
okay,
mean.
sorry.
Don't interchange the word. Look
Yes,
at
ma'am.
below the thinnest local, K max written. Can you see that on the left side?
Yes, ma'am. Yes, ma'am. 48.2 diopter.
So, your red
That is-
flag should be on. This patient comes to you for refractive surgery. You will see, okay, 2 diopter of astigmatism, thin cornea, K max is 48. This patient maybe has higher chances of going in for ectasia. Okay, let's go on to bad. What is bad showing you? Yes, now what is bad showing you?
So bad. I'll be talking about the left side first, which is depicting the elevation front, diameter maintained at 8 diameter here, and the central portion is showing +3 elevation from. This is the raw data, and then we go to the best fit sphere model, and then here what we get is that the elevation is about +7, and at the K minimum, Pachy minimum point or the thinnest local point, it is actually +8. And the difference between the normal as well as the sphere and this patient's data is coming out to be 4. So although it is lying within the normal limit, but also it's towards the borderline of the higher side of the normal limit in the front aspect. And coming to the back aspect, the first image shows us the raw data, and then when we are seeing, it is 14 and 20. So that is falling in the yellow category. That is definitely a red flag here. And when we see the difference between that, it comes out to be +10 and +9.
So for the posterior elevation, it is all right.
Yes, ma'am. Yes, ma'am.
So no, but then come to these particular maps. That's
So
what was really talked about.
The SP or DP, the background of that is changed to yellow, which is pointing that this patient has some refractive error that we should be worrying about. As we saw the earlier also, it was K max was 48 diopters, and steepening at the central 3 millimeters. Then what else?
So in any of these maps, when you are reading it, and in this kind, when you are not very sure about what it could be, you also have to add a line saying, I would like to see the patient and clinically correlate.
Yes, ma'am.
Because sometimes there could be a scar on the cornea and a localized area, which has caused a localized thinning. So it may not be an overall ectatic cornea.
Yes, ma'am.
Right. So right now, all we want as like examiners, when they're asking you, they want you to know whether you know the different parts of the map, but also very, very important to understand that you are not going to give a diagnosis just based on this.
Okay.
Okay,
If
so
it's
if
clear
you,
cut, you give diagnosis, and not clear cut, then you stay like that.
yeah, I mean, if in keratoconus suspect, doubt and all, but I would like to see the patient clinically and confirm, that will actually give you brownie points with the examiner.
This one.
Yeah, shall I go to the next one?
Yeah, please.
If suppose this patient had come to me for a refractive surgery, I would probably wait in this patient for 6 months. How old is this patient? She's, this is what?
20,
It's like 26 years.
24.
26-year-old, right?
Yeah.
So I may wait, in this patient and maybe take a history like that. But then if after 3 months or 6 months, I don't find any change in parameters, I will take up this patient for refractive surgery. But within refractive surgery also, what surgery would you like to do?
Yeah.
I mean, then I know I'm taking up the patient with refractive surgery because I know it's not conus. Okay.
Mm-hmm. Yeah. So
Anybody who answers this will
do
get
a
a gold
regular
medal.
LASIK?
Gold medal.
we can go for LASIK.
Now, which refractive surgery? You have different types. So many types
LASIK
of
for
refractive
myopia.
surgery. Which one? What else? LASIK? Why would you like to do PRK?
Thin cornea.
On thinner, it's a thinner cornea, so.
So doesn't matter. Suppose this patient is -2 diopter. Suppose -1.5 diopter sphere, -1 cylinder. Patient is very insistent, I want to undergo LASIK. I mean, I'm just giving you a hypothetical situation, but it does happen. And it's fitting very much within my criteria of residual stromal bed. So if this patient, you were to take it for LASIK, what will happen to the flap? Look at it. If you have a steep cornea, what is the higher chance of flap-related problem? Steep cornea, you do LASIK, higher chances of buttonhole. Okay? So you don't want to land up with flap-related complications. That's why, and thin cornea. So what you would like to do is what she said just now, you like to do a PRK and play safe. Any other opinion, Dr. Anil and Dr. Srivali?
No, ma'am, absolutely agree.
Yeah.
But I think it's going a little beyond the scope of their things, maybe to know about refractive surgery.
Oh, actually, we teach them. Anyway,
yeah.
It's okay. Carry on.
Yeah.
I will retract. Okay.
I think, Anil, we will require one more class on topography.
Or there will be endless classes.
No, we will require one more class on topography. So I think this particular class, yes, you can mute. Yeah. So probably this particular class, we can basically tell them to, describe a good topography, and probably the interpretation and spotters type of questions we can have in the next class. Basically by the same set of examiners, so that the children get that continuity also.
I don't have a problem. Everybody doesn't have a problem.
Yeah, sure. No problem.
Yeah, please, this is the last one we're discussing or anything more than? Yeah, sure, Vardhan. Now you happen to be right in front of me, so I don't have a choice. So just describe. Yes, tell me. Others don't want to have the video on. What can I do?
This is a pentacam cord map of the left eye of a patient who is around 20 years of age, and we can see that the K1 value is 41.4 diopter, K2 being 42.4 diopter, and an astigmatism of 1 diopter, corneal astigmatism of 1 diopter. QS is showing us that the lid is probably coming in the view or while taking the examination, and that I am guessing is pointing towards that dotted area in the upper surface of all the maps here, that the lid might be hindering the study of examination. And Q value is minus 0.36, which is fairly normal. Then we'll see the thinnest local is at 470 micron, which is again thin cornea, and K max is 48 diopter. So 48 diopter, we need to locate and find what is going on in this. Now coming to the axial sagittal curvature front, the central 3 millimeter is showing multiple colors within the 3 millimeters, including a very flat cornea, a cornea of normal corneal curvature, which is around 42, and then again going towards more of a steeper cornea, supero temporally. So this is what is happening in the central 3 millimeter. So this is a high variance between the astigmatism in the central 3 millimeter, and it is more of the corneal steepening is more towards superior nasal side, that is at 45.7. Then coming to the pachymetry map. Pachymetry map is showing purple color in the
whole lot of irregularity.
yeah,
can you read the values there?
Sir, the thinnest local is actually, as ma'am pointed initially in the first slide itself, is just way beyond the center 3 millimeter. It's infratemporally somewhere. And the central 3 millimeter is actually showing a pachy of around 1,000 or more. And so that is something which is erroneous, probably. The lid margin has caused a lot of issues there.
Actually, lid was okay. I think we made sure that the lid was not covering. This is yeah. Okay, can you go to the anterior and posterior elevation?
Yes, sir. Anterior elevation, the diameter is maintained at 8 millimeter, and best fit sphere of 8.09. Okay, so the best fit sphere is exceeding the diameter of the studied area. Then there is 7 micron plus 7 micron at the center of the 3 millimeter zone, and which is
no beta best fit sphere. This is not, you don't have to infer that it is exceeding. This is the radius of curvature. The best fit sphere is 8.09 millimeter. It's got nothing to do with the dia. Okay. So this is the radius of curvature. 8.09. Normal radius of curvature for the cornea is, what is it?
Around 5.5.
Huh? 5.5 millimeter radius of curvature. Anybody? What is the normal radius curvature?
Radius of curvature.
Ma'am, anterior, posterior are different.
44.
Anterior.
6 point.
Now we have to have another class.
That's what I'm saying. We are talking such high-fi things.
Radius of curvature. Okay, so radius of curvature will be 44.
Because based on that, these keratometry values are coming.
7.8.
Check कर लिया Google से.
मैडम भी तेज हो गई है. मैडम भी तेज हो गई है.
Sorry, say again.
मैडम भी बहुत तेज हो गई है. गूगल चेक कर लिया.
रोज होता है. ये रोज होता है इनके साथ. I know them very well. कोई बात नहीं. Nice. It's nice to do.
Yeah, and it's already given on your map there. Actually, if you see on your K1, K2, when you're seeing next to that, you have the R1 or the radius of curvature things are also being displayed.
Okay.
So you should know what your things are showing. So when you're seeing a normal map, so the corresponding things are there. So when you're eyeballing itself, you should be able to say that this is what is normal.
Yeah, this is radius of curvature written over there. 42.4 says 7.96. Okay. The normal is 43, 44.
So what is the relation between radius of curvature and keratometry?
Radius of curvature, as in case it is considering a big sphere and taking a section
higher
of it
radius
as
of
a cornea.
curvature means more keratometry or less keratometry. That's what Anil is trying to ask.
Yeah.
Ma'am, less
keratometry.
Inverse.
Less keratometry, ma'am.
So higher
Inverse.
radius of curvature means lesser
So
keratometry.
steeper or flatter?
Yeah. Inverse.
Flatter, right? So that's what this is trying to tell you. Best fit sphere is 8.09. Right?
Okay.
So this means it will be a flatter cornea. Okay. Then
So that N1 minus N2 divided by 45 equals 7.5. N1 is 1.3375 minus 1. That is 0.3375 divided by 7.5, which is coming to 45 diopters. Okay. Okay, carry on.
जल्दी जल्दी बताओ भैया, सारा रात
So
थोड़ी है।
front elevation is showing elevation of plus 7 micron at the center of central 3 millimeter, and it is showing a depression in the superiorly and inferiorly. So that means that the central part of the cornea is a bit elevated, and superiorly and inferiorly it's suppressed. Back elevation, coming to back elevation, it is minus 153 at the center and minus 53. Okay.
So can you see the cursor now?
No, sir.
Okay, fine.
No.
Okay, so it is very peculiar, the back curvature, no? See, in the upper part, you can see that it is, what is the value?
Upper part minus 92.
Yeah. Here it is plus and here it is minus. Okay. So I'll go to the next picture here.
Okay. So the front elevation, the first image shows the raw data, then the difference is all 0.
It's way above the normal limits. No, actually,
Yes,
this is a pathological cornea in which this is the other eye of the same patient. Okay. So you can see that almost all the values are well within normal limits. So actually, this patient has got a upper part. She had a adenoviral keratoconjunctivitis with a large amount of stromal edema in the upper part, immune mediated. So that is what is shown here. That is why the value came to the plus side. Okay. So normally the posterior curvature is minus. No, it is normally around minus 6, near about minus 5.5 to minus 6.5 like that. But here it was coming to a plus value. That is because the posterior curvature is really elevated. I just wanted to show you that. Okay. Yeah. Okay. I think we have many more cases to discuss, ma'am.
Whatever you say, whatever the session will say. I think we've loaded them with.
Yeah, that is true. It is almost 1.5 hours. Yeah.
Yeah.
I think
Whatever they
we
say, they have
should
to study and then come for the next class. And then we'll bombard them with 20 cases.
So, ma'am, it's like this, Dr. Srivalli and Dr. Ritu. It's like we will have, yes, yeah. So we will have 1 week, we will have a case presentation, and the other week we will have an investigation. So maybe 2 weeks down the line, next week is going to be a case presentation. I think it's a meibomian cell carcinoma or something like that, which they're going to present.
Why are you giving them the diagnosis? Then
no,
all
it's
the
okay.
findings will be put into that.
Yeah, I mean, yeah. So after that, the next week, I think we can have corneal topography part 2.
Okay, 27th. So we can do it.
Yeah.
I'm okay.
Is that okay? Dr. Anil and Dr. Srivalli also?
I'm fine.
Yeah, sure.
Okay.
Good. Okay.
You have
Well,
it
we
only
are
on
very lucky to
Wednesdays,
have
right?
so enthusiastic teachers. Ma'am is the dean of MAMC. Ma'am is taking out so much time for everyone.
I just want them to go to understand the basics. That's all. Then apply it. That's all. Nothing else.
Yeah, that was really nice, ma'am, hearing from you.
Thank you. Thank you.
The whole basics. It was
Yeah. So you can see it's very nicely Anil has talked about. Can you just go back, Anil? Because this topography they have to see. This is very interesting to very, very interesting. Even for a moment, even I was little. If you now go back further.
This
yeah,
one, huh?
this one.
Okay.
See, you look at it. Corneal thickness is. I thought you will tell me this. Corneal thickness is markedly increased over here. Look at this area. Don't go by this thinnest local here. It's absolutely fallacious, right?
Actually, on that lid thing, it was like something wrong in
it was
the.
not like that. Yeah. So here, at least if you go by this thing, it's a very, very thick cornea here, okay? And out here, maybe it's slightly, maybe normal cornea, and maybe a small point which is showing you 489. So it tells you at least one thing, that pachymetry point of view, it's a widely variable thickness of the cornea, okay? And even if you see the curvature, highly variable, flat to something normal. And whenever you will get an edematous cornea, your cornea becomes on the flatter side. That's why you are getting a BFS of 8.09. And that's why you are getting a K of 41 and 42. For a moment, I thought maybe patient has some corneal scar or something like that, some hypertrophic scar. That's what I thought to begin with, right? But then he cleared it up. So that's where the point of Dr. Srivalli comes. That say that I would like to see the patient.
Yes, ma'am.
Okay, so you could have said it's a thicker cornea, it could be edema, could be hypertrophic scar. Okay, that's fine. If Anil had not shown us those OCTs, we wouldn't have come to know about it. Okay, thank you.
So next time when these children come,
Yes.
they would be coming prepared with the basics. So we will not spend time on basics.
No,
It will
no
be
more
bombarding cases
Now
and
only cases.
interpretations.
Yes. And they have to tell us why they are saying this. That's all.
Next time it's a buzzer rum.
Yes. Yes. Thank you.
Thank you very much, ma'am. Thank you, Dr.
Thank
Ritu, and thank you, Dr. Srivalli. So we will have more action next fortnight. Thank you very much.
Thank you.
Thank you very much.
Thank you. It was a
Good
pleasure
night.
being here. Thanks, Anil, for the invite, and see you again in 2 weeks.